and uncertainty also from the Greek speaks about being thoughtful. And when one is enmeshed in sentiment and emotion around things, obviously those opinions can tend to trump facts. And facts are clearly what we need in order to embrace the problems that we have today and where we're going to go tomorrow. And if you think about the impact of skepticism on markets, I don't know what the stock market is doing right now at this hour, but certainly there have been some very evidence trends. And from the recently departed Sir John Templeton, who was a world leader in investment, actually like the uber Warren Buffett out there, he quoted that, or a quote from him said, "Bull markets are born on pessimism, grow on skepticism, mature on optimism, and die on euphoria." And I can certainly lay credence to that, given all the empty big houses in La Jolla, California right now, with people who were very, very euphoric around the housing market years ago. Facts I like, facts I can dig into. And when we think about the healthcare market and the emerging role of home health as a vehicle for distribution for healthcare unbound, I want to stick to factual dynamics in this presentation. I want us to look at why that positioning is so important and what it can mean to many of the people in this room. We look at 4 different dynamics within the context of markets: demand and supply, support, and resistance. These are objectively measurable, and here facts will trump emotions and opinions. Obviously, we're in crisis. I don't even need to spend time on this. It's been spoken about enough. All I will say is on the middle point to reinforce what you said, Liz, this morning. This is not sustainable for us to be spending potentially 21% of the gross domestic product on healthcare by 2017. And I think that that is a low estimate potentially given the current trajectory of our healthcare spending. Medicare Part A going broke. Clearly we spend more than any other organized country in the world. We're #1 in spending, it ranked 37th in world effectiveness. This was published in the New England Journal of Medicine. And those statistics have also been brought out before. So looking at the traditional supply side of healthcare, it is strained and it is constrained by multiple variables, many dynamics. It is reactive right now rather than preventative. We get that. And the silo impact, meaning the silo of a hospital, the silo of a home care provider, the silo of a disease management company, the silo of an outpatient provider, is huge in terms of our lack of connectivity and what happens to patients who have to navigate through that. I so appreciated our last speaker's talk about how much work it takes to be a patient and navigate through this. There are huge gaps in the traditional system between these silos. And as a home healthcare expert and home healthcare nurse, I can tell you that I've seen the actual impact on patients, populations, etc. by those gaps created between transitional care state and disease state management. Quick example for you. If you think about the congestive heart failure patient leaving the controlled setting of the hospital, where the nurse made sure they took their diuretic, right, and gave them a low-salt diet, and moved them into the uncontrolled setting of the home, now where they can drink pickle juice if they'd like to and skip the evening diuretic because they need a good night's sleep, you've just lost control of their hemodynamic status. And the readmission rate in that and the crisis in that, if they don't come home with a telemonitor, if it's not instituted quickly and in place, from what we've learned in terms of optimal design, says we've got risk, and we've got to manage that risk. So the gaps cost us money and human capital. The lacks of system interoperability are rampant. I have been to home health organizations where digital information comes in from a telehealth monitor, and there is a paid employee manually entering the digital data into the electronic health record because they didn't communicate. Oh, the irony of that scenario. You know, how do we make it work? We know interoperability often limits people's choices around connecting anyway. It might just be too much work. More labor, more cost, duplicative efforts, etc. Obviously a real problem for us. We know also that demography is driving associated chronic disease need to manage care and is a growing cost driver within the industry. And therefore, what we're all about in this room is that healthcare is trending away from these silos, moving, yes, into consumer-driven care that's in the least restrictive, least expensive space where people want to be, moving to the home, on and around their body. What do we know about home healthcare? Well, we've been around for a long time. VNS of New York, great presentation, loved it. Been around for over 100 years. I've worked with many providers who have a legacy of 90, 100 years. A lot of depth of experience within the setting of working in the unbound, uncontrolled space. All all right? We are always responding to changes. We have to. And the product lines that are being developed right now in home health organizations, especially forward-thinking organizations, are wide and very interesting and appealing from a business model standpoint. We work from cradle to coffin, obviously from prenatal care with complex prenatal monitoring, by the way, in the home, using technology, to end-of-life care supported with telepalliation, telehospice, which is helping people in very rural areas and markets. So it's an interesting and expanding and changing place. Dominated, though, for skilled intermittent home health by chronic disease management. We are out there working with it all the time. Those are the top diagnoses we serve. And these people also are very, very sick. The acuity level of our patients are high, and the things that are being done in the home setting may surprise you. Johns Hopkins, bone marrow transplants, performed in the home. Why? Because there are fewer resistant organisms there. A good place to do it, go figure. Sharp Healthcare, I believe the Sharp Health system may be represented in this room, I'm not sure, but was the last agency that I had a hand in operations. We were taking care of left ventricular assist device patients, half of an artificial heart, on low-dose dopamine, monitored at home. We took the CCU home in advance for those patients awaiting cardiac transplant because it was less expensive to the system, more cost-effective, and much more patient-friendly, as well as less risk of infection for those patients waiting for their transplant. So we're seeing a lot of very advanced levels of treatment and practice in the home health setting, and it is obviously going to continue. When we look at the growth demographic here of age, it's a big driver. Just between 2010 and 2020, we have a 50% growth in terms of the number of people who will be over 65. And we know in this country that they're not very healthy. At least half of Americans have one chronic disease. At least half. That's a stunning statistic. They account for a lot of the cost. And if you look at the rest of the slide, basically think about, put a human face on it in terms of the disability, the pain, the suffering, the ultimate end of life that comes, 7 out of every 10 deaths related to chronic disease. And the need then for services that will, in a cost-effective place that people want to be, will meet that need. Right? So when we look at the demand side of the equation, again, supply, demand, support, resistance, we see a growing human demand. Obviously, the work of being sick and the availability of care in this economic climate as well, consistently being more challenged as patients have to face what they have to do to be ill. When we look at how healthcare is being provided, at least in 2007, in the various sectors of the market, you can see that home care is only a tiny little sliver of the pie, 3% at that time. Why make such a big deal about 3% of the market share in terms of the healthcare system delivery? Well, given the growth demographic of need, the chronic disease prevalence, is there anyone in this room who believes that that 3% is going to go down? And the movement of care into the home, anyone who believes it might go down? My guess is, given the incredible focus right now to increase our ability to keep people out of the hospital and emergent care through your help with technology, that number minimally will be doubling soon. And if you look at a double market share, obviously that's not a bad report to send out. So, we know what the demand side of the equation is saying to us. They're telling us that what they really want is to stay home, as I'm sure you would. How many people here, if they were facing disabling, serious disease that's limiting your life, want to go to a place where everybody else around you is suffering, where the smells are different, the feel is different, the tastes are different, etc. No, we want to stay home, and obviously Healthcare Unbound is committed to making that happen. How large is our market share right now? Well, we have over 9,000 agencies in the country. The dominant players in the country are proprietary for-profit home care providers. We have a very interesting mix here of little moms and pops and large aggregators, who right now are facing some real political challenges we were talking about at lunch with respect to how they're making their money and how much money they're making. But it is a growth market coming up, and the revenues are moving along with the growth of the market and projected to keep going up. This is a 20% CAGR, compound annual growth rate. And included in that CAGR are the laggards, the people who aren't even trying to grow, who are growing despite themselves. So when I think of a vehicle for distribution of Unbound technology, I think of the growth of these markets. End-of-life care, none of us get out of here alive. It's a sad fact, but it's real. And serving people with dignity and respect and palliating them effectively, often using technology adjuncts, is obviously a large and needed market share. Within this model, we have to think about who the heck's going to do all the work out there. We know we've got nursing shortages. Shoot, they're flying in physical therapists in the Pacific Northwest to do home health visits because they can't get enough of them, and that's a doctoral level of entry. The caregivers themselves, we know, are facing the aging demographic and subject to the chronic disease. And the nurses, I'm one of them, we're not getting younger in general as a population. We are losing supply. The demand is going up for nurses. This is a study of the registered nurse population. And then the supply side of the equation basically says you've got a problem. What are we going to do? We will not have enough people to meet this demand. We have a gap created by reality here. And when I think of that gap, I loved Jay's opening comments because she spoke about the need for productivity. I think of this as a productivity gap in terms of our reality of serving the needs of sick people. How can we bridge this gap? Well, preventative care is absolutely necessary. We know we have to have it. But it's kind of spitting in the wind with respect to the demographic of chronic disease and the aging population right now. And in terms of taking care of those people, potentially just extending how long they're going to need care and health, the preventative side isn't going to solve the gap completely for quite a foreseeable time. So we must have technology in order to bridge that gap. And many, many players must come together, and home health is a piece of that puzzle, as we heard today so effectively by the VNS of New York in terms of what they're doing with pediatric diabetic management. We have to, though, in the home health industry, and believe me, I've gotten granular with it. 7 years now, almost every week on the road all over this country, you learn the reality of how people provide this care. I've seen excellent models, and I've seen models that are not as effective, clearly. And so we need to lose habit and move to best practice. And we need to stimulate thought. Skeptics, for me, make me want to dig into the facts more. They make me want to say, what is the truth here? I want to know the facts about what best practice is. I don't want to render an opinion. Once I have the facts, it's not about what I think or what you think or what you think. It's about the facts. From there we can postulate. From there we can make decisions. So integrating best practice into these agencies' performance, critical. Integrated technology, huge. And FASI has been a research engine for the industry studying the integration of technology and telehealth, both back office for revenue cycle management and efficiency, point of care devices, electronic health records, telehealth, remote monitoring, robotics. Mobile internet tsunami is on us. I cannot wait for the leapfrog technology that's going to take place here. It is exciting and certainly something that we feel we can completely take up, and we did get a little taste of already today, which is great. When we think about the cost of care, just on a comparison, and this slide's a little tricky because we clearly can't compare what the cost to do an appendectomy in the home would be versus the cost of doing an appendectomy in the hospital. But although maybe, bone marrow transplants in the home, who knows where it's going to go someday. Think about the cost of taking care of a very complex decubitus ulcer patient who needs IV antibiotics and is on negative pressure wound therapy. We're taking care of those people in the home very effectively now at a significantly lower cost than we can in the hospital. It's a strong argument for moving care to the Unbound space. We have learned, and these ideas were actually generated through Intel, Dr. Monique Lambert. She and I spoke on Saturday, and she said, yeah, go for it, Cindy. I think Homecare's got something to say here in this equation. And so we talked about moving best practice to exception-based population management, which means, as has already been alluded to, not scheduling a visit or a contact with a patient when it's convenient for me or when I think you need it, but going based on what the devices potentially can tell us as they peer into and illuminate the black box of pathophysiology. When is it that we have to go? When are our services needed? There clearly won't be enough hands to support habit and ritual. And yet rituals make people happy. I think the most popular class at Harvard right now is a course called Happy. Right? And one of the things that they're teaching about is, that rituals make us happy in human behavior. Losing ritual, moving to exception-based management, critical. Reducing the degrees of separation between the clinical decision maker and the patient has to start early. And when I heard the statistic of 17 years, Gary, was that it, 17 years for a doctor to change their behavior? Basically once they've learned a fact. I was just like, oh, my brother out there, I wish we could go and scream this from the rooftops. Do you know what you're doing when we don't have a protocol in advance of that hemodynamic shift with the congestive heart failure patient that says, hey, Homecare, don't worry about what we can predict in terms of an incremental weight increase when the patient goes home and they start skipping their Lasix and drinking their pickle juice, because they missed that salt that they didn't get in the hospital. We'll give you the protocol in advance that says you can double the oral loop diuretic. In advance of diuresis, you can push the Lasix and draw potassium. 80% of what they do for patients in emergency rooms right now, for our home care patients, we have found could be replicated in the home setting. 80%. That's significant. But it means we've got to reduce the separation here and get with the decision makers who can write the orders to allow us to have protocols to drive our care forward. The third point I put in italics because it is a very sweet spot for home health care. And it's a very clear support for this delivery mechanism. It talks about triangulating data and constructing mental models. And if I have to take that jargon apart and think about what it really means to me, it's that healthcare only works the way you want it to when the patient is fully understood. How can we understand what's going on with the patient? Technology will not replace a great history in physical, nor will it replace the experiential depth that one has when they get into the unbound setting of the home. It has been found in research studies done by Intel that the home care clinicians who understood the space of care provision in the home setting trumped other delivery methods because they knew how to put that information into context with patient need, patient behavior, and what happens when we try to move healthcare into a space that's consumer-driven. Okay? Very important. Telemonitoring, evidence-based practice do nothing but empower the top three that will allow us better success to achieve best practice. Now, FASI did a study recently. We worked with Philips on a very large technology study 2 years ago, and this study is not yet out for public consumption, just came out of the lawyer's hands at RIM, BlackBerry RIM. But we did the National State of the Industry study in conjunction with the National Home Care Association. We got a representative sample of the industry, over 900 agencies representing all the different legal entities out there, and went to town to try to learn more about our industry. I want to bring you some very interesting facts that we found with respect to technology out of this BlackBerry RIM report. First of all, we know absolutely that quality was positively impacted by technology, no question about it. And when I think about the three pieces represented here, it's not surprising to me at all. The first was that 70% of agencies, let me back up the truck. I'm about to use an acronym that's home care specific, and I don't want to do that to you. HHC is Home Health Compare. The home health industry right now is paid based on the gathering of a data set. We measure patient status functionally at the start of care and end of care, and out of that we measure outcomes, including emergent care rates and acute care hospitalization rates. And everybody's job is to get them down because we're on pay for performance demonstration right now. Last year, 2009, the home care industry was paid out its first bonuses under P4P for reduced rehospitalization and emergent care rates. So we're motivated, and we're really frustrated with those docs who are taking 17 years to move with us. Okay, so, but anyway, we're motivated. So that's HHC, Home Health Compare, and we look at the top third of people in terms of those quality outcomes. 70% of them used an electronic medical record. 60% of them were in the bottom third using the electronic medical record, but still 10% difference. Telehealth. 34% of the agencies in the top third of Home Health Compare utilized telehealth, not teleheal. Sorry about that. The bottom third, only 14% used telehealth. Video-based telehealth, I love this correlation, kind of fascinating, but it needs a lot more data underneath it to understand the granularity of why. 21% of these agencies were in the top third of Home Health Compare, 0 use of video telehealth in the bottom third of Home Health Compare. What does that tell you? Potentially, it could tell a very interesting story. Further support for the work of telehealth integrated into home care. When used, 75% overall improved the clinical outcomes in the aggregate on the Home Health Compare data set. 66% lowered the hospitalization rate with the use of telehealth. That is salient. It's huge, undeniable. 57% reduced that emergent care. And very interesting to me, when we talk about consumer-driven healthcare, changing health behavior, how do we get people to go with the flow, operant conditioning, whatever you want to call it, 61% increase the patient's ability to manage their own disease in the home. That also is significant. The teaching and the mechanisms of learning underneath repeated stimulus response is high. 28% lowered their costs. Now, I work both in advancing clinical models, but also redesigning the company so that it can remain in business and thrive in a new model. And I'm very interested always in reducing expense to revenue and my gross profit margin, because why wouldn't you be? 28% did that with the use of telehealth. 44% reduced the number of visits, enhancing their profitability when paid by an episodic rate within a captured population of people. 46% increased their referrals. We can do this for your patients. And now, if we look at the rise of accountable care organizations and partnerships across the continuum base to try to reduce rehospitalization and own it in your pocket, this is salient, and Homecare has something to contribute and offer to these folks. In fact, the applications here are huge for us in terms of what we can do. When I think about the current applications for biometric monitoring for CHF, diabetes, etc., huge with remote monitoring. This was the low-hanging early fruit of our industry. Telewound management, telepsychiatry, psychiatric nurses, behavioral health, critical, and boy, can I increase their productivity if they can make 12 contacts in a day or 18 contacts in a day as opposed to 5 visits in a day driving around. And we know depression for the congestive heart failure, diabetic, etc., leads to incredible rehospitalization rates. So the use of psychiatric home care, behavioral health home care for treatment of depression in the comorbid chronic disease patient, huge, and we can get incredible, with video, bidirectional, telehealth, incredible outcomes based on treating it and recognizing it. Fall prevention, number one technique to reduce avoidable rehospitalization in the elderly, obviously a big thing, as well as telepalliative care. Only 23% use them now. Hey, it's a big growth though, if we look at it, 35% increase from the 17% in 2007. But what is support to me for an industry could also be seen as resistance by a skeptic, right? But we've got to sell the idea. We've got to position the use of telehealth. And we've got a lot of resistance, obviously, from both boards of directors, CFOs who don't understand the investment, etc. And when we look at the economic climate and reimbursement uncertainties driving your decision to spend on technology, this was a survey that was informal. There were about 350 people in this cohort. But just on asking whether or not the reimbursement uncertainty is going to impact whether you spend, there are a lot of skeptics in the yes answer. There are a lot. They don't see it as an investment. They see it as an expense. From the patient population, what we learned from the Philips National Study for Technology was that fear of equipment, intrusiveness were the two biggest factors why patients said no. And yet I know that's easily overcome. How was the technology introduced to the patient? How were they led to believe? How did we position it? Leadership sells ideas. Leadership sells ideas. How can we innovate and execute the vision? We know the future of Unbound technologies are huge, some of it kind of exotic. I won't read this to you because I know we can't. But if we think about where it's going, the bottom one is very important, concierge monitoring. People doing this on a private pay basis as well, with the expertise of home health at the helm in terms of understanding depth of space, that triangulated relationship, critical. Some things like neurorobotics, Myomo. I just did a redesign on a company outside of Boston who's the first agency in our country to use this. This neurorobotics teaches paralyzed limbs how to move again with feedback from an EEG that says, my arm wants to move, but it's hemiparetic, I can't. Yes, you can. A robot's going to teach you. And we're getting incredible outcomes from that. The future of home care, I think, evolved is to continue to reduce morbidity, mortality, keep people where they want to be. Skeptics, I love you. I think it's welcoming because it forces us to revisit facts. It's also indicative of an early bull market. And the facts absolutely support home health care, I believe, as a natural vehicle for adoption of home health technology and healthcare Unbound. And with that, I thank you very much.
We have time for one question. Mike.
Anything about changes in the several pieces of national legislation that approved beginning with the untapped and now including healthcare reform and touch on home health?
Well, I think the accountable care organization interest, the medical home development model are key for us in terms of effective partnership. In terms of the legislation itself, not directly, the increased notice though of care in the home and advancing care in the home obviously will have an impact on home health depending on how we use it. I think, Mike. So, thank you.
While she's setting up,